Welcome, everyone. Welcome to another VITA Learning remote webinar. Today we have Dr. Julian Conejo. He is going to talk over the material selection by indication, not always a choice. Hi, Julian. How are you today?
Hello, Jim. Doing great. Thank you.
Excellent. So I do want to point out to everyone on your screen, I'd like to tell everyone that if you have used VITA blocks in the past, the new VITA blocks that you'll be getting, they'll be rebranded with a new logo on them. So as you can see on your screen, they have kind of like a new emblem, a new branding, if you will. So that's true for all the VITA blocks family, which is the Mark II, the Trilux Forte, the Real Life, and then the Trilux Forte now comes in a multicolor always, but a 0M1 and a 1M1 shading as well. So we've gone to some brighter multicolor units there for Forte. Just to let you know. So let me start here. We have Dr. Julian Conejo. Your phone during the presentation, your phone will be on mute. So if you have a question, go ahead on that panel that pops out on the right hand of your screen. You want to go into the question box and just type in your question and send it through. We are taping this, so it will be recorded and give us a couple days, but it will be presented onto our social media platforms, VITA North America, YouTube, the Instagram, Facebook, links to that with LinkedIn as well. We will do a question and answer at the end of the program. So if you have questions, you can type them in or raise your hand. I'll let you ask it live, but type those questions in, and then we'll get to those questions as soon as possible at the end of the webinar. So as I mentioned, we are posted on the learning website of VITA. So please join us. We have a lot of webinars. Dr. Conejo has done several this year, and those are posted as well. So Dr. Julian Conejo, dentist out of UPenn, he obtained his DDS from the University of Latina, Costa Rica in 2005. He's a young guy. And then completed training as a prosthodontist as well at the University Intercontinental Mexico in 2008. He's a visiting scholar at the Department of Preventative and Restorative Sciences, University of Pennsylvania, Philadelphia, UPenn. He is not just a instructor, dentist, but he also does clinics as well as private practice. So he's got a very depth of the reality of what you encounter in real life. So he has an opportunity to go through the workflow. He does a lot of hands-on, and then he actually sees what it looks like in the mouth. So he can understand and do studies as well to see what materials work best in what situations and how to prepare things. So this whole material selection by indication, not always a choice. Sometimes, the patient, what's presented dictates what indication, what material to use. So this is very nice. Everyone's going to enjoy this with Dr. Conejo. As I mentioned, Dr. Conejo practices clinical dentistry, conducts extensive research at UPenn. He is the current clinical CAD/CAM director at UPenn, and from his research and experience has written several peer-reviewed articles and studies. So Dr. Conejo, I am going to go ahead and make you the presenter. And as soon as I see your presentation, I'll let you know, and we'll let you get going.
Excellent, Jim. Thank you so much for kind introduction. And I think we should be all set, right?
Yes, we are all set. I see your presentation, so I will see you later.
Excellent. Thank you. So hello, everyone. Thanks a lot for joining this webinar. Thanks to VITA North America for the organization and Jim, of course, for moderating. So today, as in other opportunities, we will be talking about ceramic materials, but today I wanted to emphasize on how have we evolved from where we started using chairside CAD/CAM dentistry, and how many things have changed, but others have been maintained through time with validation, both in the clinical and the scientific world. So, as Jim mentioned, please feel free to just type in any questions. I don't want to extend the webinar um, that long, so we can have a time at the end, Jim, as usual, to have some Q&As and some comments. That's the idea. Trying to make this webinar setup as interactive as possible. Okay, so we will get started as Jim was saying. For those of you that haven't heard past lectures, I'm from Costa Rica, and I've been started working there with chairside CAD/CAM dentistry in January of 2010. At that time, the material that we had was VITA blocks, and it was mainly the VITA Mark II feldspathic material. As being trained as a prosthodontist on many traditional procedures as well, back at that time, I was, trying to make the preparations perfect and try to do full mouth rehabilitations. And in many cases, I actually did crown teeth that today in 2020, 2021, I wouldn't make a full coverage restoration. So these are photos probably I took maybe 10 years ago. And going to the starting message is that these traditional procedures, when we're working with full mouth rehabilitations, typically involve the use of full coverage fixed dental prosthesis. That's how we were trained, and we know that that also involves a lot of healthy tooth structure that it's lost because not all the teeth are damaged in the same way or in the same quantity. Okay, in many cases, additional endodontic treatments were needed, and that's something that doesn't makes me very proud of. When I prep teeth, let's say lower incisors, lateral maxillary incisors, they are very thin teeth. It's close to get a pulp exposure, and then from the restorative side, we're actually causing that tooth to need root canal treatment. So now, yes, we do full mouth rehabilitations, but we've evolved from this. And if the tooth is vital, we would go for partial coverage restorations focused on both function and aesthetics. Okay, so this is how I was initially trained, and many of you also might agree on this aspect that I'm showing here. And I would like to start showing you, let's say, the evolution we've had through the years working with these type of procedures and materials. So when we're faced with a challenging patient, right, a patient maybe severe grinder with a lot of wear, maybe prominent masseters, and there's um, parafunctions, that stresses us, right? We need to go through a checklist, and we need to make a lot of decisions. Most of the important decisions during the treatment plan phase for me is, of course, the selection of the restorative material. And this is very important, but also there are many other decisions that are as important as selecting what material am I going to use for the final restorations. Also, we need to discuss what will be the best impression technique. When we started with chairside CAD/CAM dentistry with the CEREC Blue Cam, we had to use the Opti spray, and the quality of the image was very good. But when we were trying to extend to full arch impressions, it was very difficult. So sometimes we had to break the treatment in different phases to be able to make digital impressions of different quadrants and have different files, and it was much more complicated than what we are able to do now. We still use the CEREC, and what we can do with PrimeScan now is it's amazing. And I wouldn't say that I'm against PVS impression material. If there's any situation because you feel that you could get a better result in that specific case, there's an area that is too subgingival, that there's an area the bleeding is not allowing you to get the perfect intraoral scan, then you can still use that as a backup. I heard that we're as good as our plan B, so I would always have also some conventional impression if you need it. I haven't used it for a while, but not because I love intraoral scanning and love how the technology has evolved. I'm against other techniques that have worked in the past. That's kind of the message there. Of course, we need to talk about occlusion, right? I believe that what it's not wrong, we shouldn't try to fix it, right? We should be simplistic. But in cases where there's big loss of the vertical dimension of occlusion and there's wear patterns, we need to really plan how are we going to restore this patient to protect not only the ceramic, but most importantly, those abutment teeth supporting these ceramic restorations, okay? So when we talk also about full mouth rehabilitations, I don't make 28 restorations in one same day and deliver the same day. That would be really crazy trying to attempt that, so many hours in the chair, so many hours designing and milling, right? So I want to make my digital dentistry workflow stress-free, but trying to maintain a high level of quality, okay? So the topic of provisional restorations is also something important to consider. Here you can see some photos of all the VITA blocks, but there's the VITA CAD temp, and that's a great material for this type of provisional restorations, because these will also let me have different segments of provisionals. I always like to have the 6 anteriors as one unit, and then the posteriors on the left side as one other unit, and the posteriors on the right side as another separate unit. And then when you're going to make your buccal scans, you can just maintain the provisionals in the front, and that will be used as a jig to provide you with the ideal vertical dimension. So investing time on your provisionals, investing time on getting these blocks and costs will help you try to deliver the final ceramic restorations barely with no occlusal adjustments. And of course, the final component there, cementation, we will talk a little bit about that, but if we know how to treat the ceramic, how to treat the tooth and bond properly, we can use feldspathic ceramics basically for every indication out there. So started with the traditional procedures, which I'm not that excited of making them anymore, only for specific situations. And what about the actual procedures? So with the new adhesive techniques and restorative materials that we have, all these traditional invasive procedures have been replaced by more conservative approaches. So this was one of my first publications. I still remember this case, maybe 12 years ago. Pec laterals, very healthy teeth, young female patient. I just packed a cord, softened the incisal edges, and then we went for prepless veneers with feldspathic ceramics. So we need to decide what is our final point, and then go back and see if I need to create space for that, or it's only a additive restoration and additive procedure, so I basically won't be removing any healthy tooth structure. I think this is something we need to go case by case, and not as I was mainly trained of, okay, crowns, a lot of invasiveness, because we will affect the pulp and the tooth vitality. So as we started working more with partial coverage, actually this is a photo of the first CEREC case I did. These are inlays and onlays with VITA Mark II blocks. And now I have a follow-up of 10 years now. These photos I think were taken 3 or 4 years ago. And you could see that at that time, the technology that we have in the software was very limited. We couldn't work with 2 adjacent restorations at the time, so we had to design one, make like a virtual seating, and then go ahead and design the neighbor restoration. But something that I like seeing these type of preparations, these are feldspathic ceramics on a first and second molar. what has been the success of these restorations? Well, that we maintain sufficient material thickness, we maintain margins as supragingival as possible, and with the proper rubber dam isolation, we were assured that the adhesive cementation was done properly. And that combination of factors is what gives you the longevity on areas of heavy load like the molar region with feldspathic ceramics. Do I go with feldspathic ceramics nowadays for every second molar out there? No, not necessarily. But what I want to mention here is that if we have those basic principles, the flexural strength of the material is one more thing to consider, but it's not the most important aspect. Okay, sometimes I see that we might be using even zirconium oxide for situations that we don't really need it, and I might be one of those also exaggerating on how I want to overprotect the situation by using zirconia. But this really shows us that maintaining these principles of providing material thickness, providing supragingival margins, and isolation for adhesive cementation makes these restorations become part of the tooth, and they have been very successful. So let's go through a few studies. I don't want to get you very bored today showing a lot of literature, but this is a clinical performance of CEREC AC Blue Cam conservative ceramic restorations after 5 years. And here there's a 95.5% after 5 years. Okay, so the fracture rate of ceramic restorations was significantly more in non-vital compared to vital teeth. We need to understand that difference. If we are facing an endodontically treated tooth, nowadays, 2021, we still go for more full coverage restoration if this is an anterior tooth, okay? And if it's a posterior tooth, we will go with an indirect ceramic restoration that will protect all the cuspids. We want to have that biodome to protect the tooth from any vertical fracture, okay? So it's important to keep that in mind when we're doing the treatment planning phase for these type of restorations. Then we started doing a lot of porcelain laminate veneers. I think this was the start of the CEREC 4 software, maybe around 7 years ago. And this colleague of mine, she wanted to improve her smile. So sometimes we did only maybe 4, 6 veneers. That's a very common procedure we all do on a regular basis. So we can do inlays and onlays, as I just showed you here, being conservative, bonding well. We can also work on the aesthetics and the anterior teeth, not needing to crown all the teeth when we want to improve the aesthetics, but we can do partial coverage veneers. So this all introduction is just to go to the next step. What does the scientific evidence shows us? That partial restorations like inlays, onlays, and veneers show high success rates. So this works, it's proven. They are typically used for partial, hemi-arch, or single unit restorations, right? We all agree many times we have a fracture amalgam and we do a single unit only, and that's fine. Or like this colleague, she wanted 4 veneers and the maxillary incisors, and we do those 4 restorations. So these concepts of partial coverage restorations is what we are implementing now in the world of full mouth rehabilitations. So before I go on the detail of the protocol on what I do on appointment 1, 2, 3, and 4, we would like to go through some other important concepts. So no matter what material we are using nowadays, whether it's VITA block, whether it's a zirconia material, we always need to think about insertion axis when we are in the clinic, okay? Because the softwares still today need to have a proper insertion axis to create a restoration that will fit, most importantly, but also that the initial proposal of the design is something that is in harmony with the adjacent teeth. Sometimes we receive emails or messages in Instagram, like, I'm not getting very nice initial proposals. What is the reason? Software is not working well. And I say, well, send me a screenshot of the preparation. And then you might see that the preparation is not in harmony with the adjacent teeth, with the arch. So the software is confused. It doesn't know exactly to consider which insertion axis of the prep tooth or the adjacent teeth. So preparation is only carried out to create a path of insertion for the restoration, okay? And minimal invasive indirect restorations maximize tooth structure, as we all know, by keeping the restoration margins in mainly enamel. Of course, we will always like to bond all the partial coverage restorations to enamel, but that's not possible. But at least when we have that periphery of the preparation on enamel, we can seal very well, and that will be sealed for the longer term when compared with dentin. So you can see these preparations, they are partial coverage. I'm not going for full crowns. If the palatal aspect is fine and I can maintain it, then I will do these type of 3/4 restorations or wrapping around, but always trying to have enamel to bond to these ceramic restoration. So when we talk specifically about ceramic materials, these restorations can be pressed or milled using CAD/CAM technology. Personally, I've been more involved with the CAD/CAM world and have been milling much more for the last 10 years that I've been pressing, okay? But we understand that both workflows are very good. Some are more dependent on the ability of the person when we are doing the wax-ups and making the press restorations, but also because they have a technician there, they could work and achieve ideal margins, even if the preparation is not outstanding when we're doing pressables. But in CAD/CAM, we need to make sure that our preps are really, really good, because we don't have that luxury of someone is skillful enough to take time to make that restoration fit. So going back to the materials, we know that silicate ceramics and hybrid ceramics are strong enough to resist in the posterior region with a thickness or width of 1.0 millimeters. So if I need to take home one number, I would say always make sure you have at least 1.0. Why? Because the restoration would be as strong as its weakest link. So if you have a thickness of the ceramic in the functional cusp of 2 millimeters, but in the center fissure, your reduction is not anatomical and you have only 0.7, that's where you will probably have the start of the fracture and the crack, okay? So we want to have homogeneity on the reduction, anatomical reduction, to maintain this throughout the entire tooth, okay? We're going to go through some concepts on occlusion, trying to keep this as simple as possible. But if I would be this patient, I got a endo-treated maxillary first molar, and I need a full coverage crown, for sure I will get this in maximal intercuspal position, MIP. It's the best relation between antagonist teeth independent of the condyle position, right? So this is a tooth-to-tooth relation, indicated when a limited number of restorations is performed and no occlusal scheme changes are required, right? So we do this on a regular basis when we're doing single restorations, quadrants dentistry, maybe 6 anteriors, treating 6 to 11 to enhance the shade and enhance the shape of the smile. So we will work in maximal intercuspal position. But when we are working with cases of more wear, severe parafunctions, and we can see that the lower third of the face has actually been reduced, then we need to restore this patient back in an ideal or close to ideal position, which would be our centric relation position, CR, right? So with this slide, we can have a discussion of the whole morning and afternoon and have many different opinions and thoughts, and I totally understand. But basically, I just want to make sure that we understand that we need to prep to restore the vertical dimension. We need to try to go to centric relation. So It's a relaxed, loose, muscular position, not related to the contact of maxillary and mandibular teeth. And it's the starting and finishing point of every articular movement. So when some of our students ask me, how do you know if you're really on centric relation? I'm not really sure that this is exactly that position, but if I see that that patient comes and goes back to that same position without me being excessively manipulating, that's something that is going to work pretty well. So it's the starting and finishing point of every articular movement, and we don't want to fight that, okay? So those are some videos from a production that VITA made many years ago for the VITA PhysioDens teeth, and I really like how this gives you a very good visual help on how the teeth are distributed to better support the forces going from the center of the head to the base of the mandible. Okay, and how you can see the working cusps and the intercuspation. So here we can understand that the preparation needs to be very anatomic to maintain that magical number of 1.0 millimeters of thickness overall the restoration. Okay, so the other concept is the vertical dimension of occlusion, which is basically the distance measured between 2 points when the occluding members are in contact. So for example, here I'm using a digital ruler and I'm measuring from the cervical margin of number 9 to the cervical margin of the lower left central incisor as well. Okay, so here I can start re-establishing an ideal vertical dimension of occlusion. So how do I plan this? I think of edentulous patients in these situations. When we make a wax rim and start from scratch, same thing I would do here. I would focus on the incisal edge position, on the aesthetics, make sure that we can see the incisal edge at least 1 millimeter, 1 to 2 millimeters, and then recreate. Look here, the incisal edge is basically touching, right, the soft tissue in the maxillary arch. There's no space. Whatever you restored in this position, you would most likely have fractures. So if the prosthetic rehabilitation involves at least one complete arch, we have the possibility of increasing the vertical dimension of occlusion, and that will minimize the invasiveness of the procedure. This is one of my favorite slides from this lecture, because it's telling me that I can increase the vertical dimension or re-establish it, take the patient to a more of a centric relation position and not that parafunctional position without needing to invade the 28th teeth. I could maintain only restoration of one full arch, maybe the maxillary arch, okay, and work some of the teeth in the lower that need to be restored without having to really invade the 28th teeth. Permanent increase of the vertical dimension of occlusion up to 5 millimeter represents something safe and predictable without detrimental consequences. So this is a great book from Dr. Mauro Fradiani from Italy. I would really recommend to go through that book from Quintessence if you're really into full mouth rehabilitations. It's a great sequencing, and I study and learn a lot from his work. So increasing the vertical dimension of occlusion necessarily involves positioning the mandible in centric relation. Why? Because we are deprogrammed and we don't remember anymore that MIP position. The MIP position will be automatically lost once the teeth of one entire arch are grinded or are prepared. Okay, so we need to understand this. So how I face this, many times I would like to start prepping by quadrants, and I will go and provisionalize chair side with a putty matrix and a bisacryl material in MIP. Once I move to the other side and I finish the entire arch, then I'm going to create a new set of provisionals at the established vertical dimension of occlusion. So we understand that we want to have anterior guidance, and it's the influence of the contacting surface of the anterior teeth on tooth limiting mandibular movements. Why I want to bring this up? Because if I'm reestablishing that vertical dimension and I'm making, let's say, onlays to all the posteriors to increase that dimension, sometimes I would need to involve the palatal aspect to be able to have an ideal anterior guidance. So it's something that we need to consider case by case. If what I'm augmenting is very minimal and I can create a nice anterior guidance without prepping the palate, then I will just go with veneers on the front, okay? As you can see here, that's what we want. 4 mandibular teeth simultaneously disoccluding with the 2 central incisors to have protected occlusion. So now let's get to the clinics and let's get to the practical part. So this is the minimal invasive full mouth rehabilitation protocol that I've been using for many years. And it's basically a sequence of 4 appointments. I think that everything we study, everything we research, everything we learn and the theory, it's really worth it and really valuable if we can implement it in the clinic, okay, on every single day. So it needs to be practical, okay? Here, I like to have this sequence of 4 appointments, and we will go one by one. There are some procedures that we do in the clinic and some other procedures that we do, let's say, digitally in the digital lab, okay, or without the need of having the patient there. So we will start with the first appointment, and that's basically how we collect the data. Okay, let's go through a case, and the first appointment is the collection of the diagnostic elements, okay, in the clinic with conventional tools like x-rays, probing, vitality testing, and so on. And then in the digital procedures, of course, we would need to do an upper and lower pre-op scan. Instead of using alginate impressions, we'll go with intraoral scans. So these diagnostic elements, as I was saying, are very important, but we need to make sure we do an evaluation of the vertical dimension of occlusion. Okay, so here I will tell the patient to relax, sit down, guide the patient to rest position, lips slightly separated, and then make the measurement from one point in the nose to one point in the chin. Repeat it 2 or 3 times, get that average, then tell the patient to bite down and close in MIP and make that measurement. So we know that the difference normally should be around 3 millimeters. If the difference is about 6 or 7, I know that I would need to reestablish probably 3 millimeters there to treat that patient in a more adequate vertical dimension of occlusion. So it's basically thinking of each patient as an edentulous patient, same tools that we use for checking this. So I had this patient case that we did probably around 7 years now. Not happy with the aesthetics, parafunction, discolored teeth. How I was trained a few years before that was basically doing a lot of full coverage restorations, right? So here we go. We start at rest position, and we know that we should be able to see those incisal edge position of the maxillary teeth at least 1 millimeter in this age of patient, male patient. So we don't see anything. So this is telling me that we would need to lengthen those maxillary incisors. Then on the photo of a full smile, I like to check this and say, well, I don't have any high smile. So if I have a slight recession on one of the teeth, I don't need to worry that much about that situation. That's not going to affect my case aesthetically. And I could be also more conservative without needing to indicate multiple, let's say, soft tissue grafts and multiple surgeries, which not all the time is something attractive for the patient. So this initial data collection is so important for this type. So then we can make intraoral scans. Nowadays, with the quality of the intraoral scans, we do less and less intraoral photos. But here you can see that we have failing restorations, direct composites from many, many years. And we have loss of enamel in both areas with occlusal contacts and areas without occlusal contacts. So this might be a little bit disturbing to try to diagnose perfectly these type of combination cases where we have different situations, but we got to pay attention to that. You see the maxillary canine, how there's a big loss of enamel on the cervical third. And when we go and check also the occlusal aspect, we see this traditional cupping, right? we see these holes on the occlusal or pits at the occlusal surfaces. So this is telling me that this patient is having multifactorial pathology in his case. Okay, but we know that the incisal edge is not visible, that there's more difference between the rest position and the maximal intercostal position. So we need to create a more integral diagnosis. So this is erosion, abrasion, and attrition. It's not only one, it's the three. It's a Bruxer patient, and there's exposed dentin. That's what the patient is complaining on the posterior. There's multiple failing restorations, diminished vertical dimension of occlusion, and non-favorable aesthetic. So for me, the diagnostic needs to be very simple, but very clear. So now we go with the strategy, how we are going to solve this situation. As I said, we did this case 7 years ago, and back at that time, we were also using the digital smile design concept. Why? Because it make it more simple to communicate with the lab where we need to add, where we need to move, where we need to shift. Okay, so back at that time, we had basically a Keynote software or a PowerPoint software, and we had these tools that would help us in a very basic way measure the length of the teeth, measure the proportions. So we always start with the anteriors. We idealize the anteriors, and then we create the space in the posteriors to have a harmony transition between anteriors and posteriors. So this also is shown to increase patient's case acceptance when we explain this to the patient. Okay, Dr. Coachman has been, I think, the pioneer on this concept, and here with these simple lines, we could really explain to the patient that those teeth are very short because of the parafunction, of the different habits that we discussed, and we want to reestablish something. But to make these anterior restorations work, we also need to work on the posterior teeth to provide good occlusal contacts to protect. So how do I know how much I need to reestablish the incisal edge position? I go to the natural ratios. So the width of the tooth is not changing. So I measure the width, and by then I do the math and I come up with the length. And then with that length, we do the wax up, whether it's manually or in the computer, most likely nowadays. And then we come and make this prototype in the patient's mouth. So this is a publication from Dr. Belzer in the European Journal of Aesthetic Dentistry, and this is the three-step technique. So the step one is everything about aesthetics. Okay, we want to work on the maxillary vestibular wax up to assess the occlusal plane. Now, when we've lengthened the incisal edges, we've made sure that it's parallel to the interpupillary line, that it follows the smile line. Then we go to the second step of the wax up, which is the posterior support. Here, we want to wax up the occlusal surfaces of the posterior teeth, and this is the creation of posterior occlusion at an increased vertical dimension. Okay, so we don't start in the posteriors, we start with the aesthetics, and then we adapt the posteriors to be in harmony. And the step three would be the anterior guidance that I explained already with the video. We want to have this maxillary anterior palatal surface idealized as well. So you could go with a palatal veneer, or you could go with a full coverage restoration when you are reestablishing too much the vertical dimension, and that will give you a new final anterior guidance. So this table has been very helpful for me because I use this to talk with the lab technicians and discuss how we're going to approach. Okay, so this is an example. The traditional wax-up was made 7 years ago, but it's following this facially driven treatment planning approach. Okay, so what's my plan? I'll do veneers. This is international numbering of the teeth, but I'll be doing veneers on the maxillary incisor teeth with VITA Trilux Forte 1 and 2. We'll do full veneers, basically wrapping around the tooth, but without needing to prep the palatal aspect because it's already worn down and we are opening the bite. So it's almost like a prepless crown in that aspect, okay? We call it a full veneer on the maxillary canines with the same VITA Trilux Forte. And then we'll do the von lace, which is a combination between a veneer and an onlay in the maxillary cusps, bicuspid, sorry, in the bicuspids. Why? Because we want to make sure that we get them in function. And in the molars, we go with onlays. And here we had the VITA Suprinity, which is a material with a higher flexural strength. And in this type of patients, I think it's a good idea to use this for the molar region. In the lowers, we work with same onlay concept for the molars with VITA Suprinity, and then just occlusal direct composite resins and incisal resins on the bicuspids and the canines, and of course a night guard. So this is really nice because we can combine direct and indirect, but having a overall understanding of this treatment. How do I select the shade? Well, I like to use the combination of the spectrophotometer, the VITA Easy shade. Nowadays we use the advanced that has the app as well, so you can take the photo, you can by Bluetooth connect that to your phone and give the lab technician a very valuable source of information with the photo that you take and also with the information of the spectrophotometer. VITA Easy Shade, this is the linear guide, which is really easy to work because it has everything separated, and then you can start by group of value and then you go to the specific chrome and hue that you need. So these teeth are very dark. I would say they are in the group 4, M2, something around there. So I start doing some bleaching trays, and we go with the bleaching for a week, and then I'm not at the 1M2 that I want to get, but I want to use feldspathic ceramics. It's very translucent, but I want to enhance the shade of those future abutment teeth. So that's why I like to do the whitening for a week, check it, and then wait one more week, and then I go ahead and start the preparation. So I help myself with the whitening to be able to use feldspathic ceramics, which are the most translucent material. Okay, so for the second appointment, I have my wax up. Okay, and we are going to create the upper preparations and provisionals. Okay, and I'm not able to prep upper and lower teeth at the same appointment. It's too much, but I will do just a lower mock-up, and then I will be able to take this patient to the new vertical dimension of occlusion. So second appointment, we focus on the preparations of the maxillary teeth. 2 years ago, when I moved here to Philadelphia, working with Dr. Platz, we came up with this preparation system for CAD/CAM restorations, and I think it's great because only with 13 burrs you can prep any type of partial or full coverage ceramic restoration. And nowadays we want to focus on maintaining enamel. That's why we have this depth cutter burr of 0.3 to maintain the enamel on the cervical portion of the anterior teeth, because that's the thickness of enamel over there. We want to make sure that our shoulder has an internal round angle, and we have this ultrafine burr needle point to smooth out every sharp area that we find in the preparation, and also a football shape with a red line diamond burr, fine diamond, to smooth out the cingulum when we need to create full coverage restorations. Now also we've tried to implement better and newer instruments for soft tissue retraction, and not only retraction but protection, because many times I will tell my student or a resident, you know what, let's refine that margin, let's bring that margin 0.5 down so we can support that papilla if we're working the aesthetic zone. But if I don't protect the tissue when I'm refining, I'm going to make it bleed, and that will complicate my scan. So with these soft tissue protection instruments, we can accomplish both things. We can refine and then have a very dry and controlled environment for the final preparation. And of course, we do everything under magnification, at least 3.0 magnification on your loop. So we know that a medium bird to prep and a fine bird to prep gives us the best marginal adaptations. This is some specimens I did with VITA Dynamic, and we can see marginal adaptation of up to 11 microns, which is extraordinary. And these are the photos of the birds from the CEREC system. So we want to match what we do inside the patient's mouth with what the machine is doing when creating the restorations. Also, ultrasonic tips are very helpful to smooth out the preparations, the margins. This is the perfect margin system that I've used for a few years. So here, when I'm prepping the veneer, I'm thinking of the final outcome, but I want to make sure that at least I have 0.3 in the cervical and 0.5 in the midfacial, and try to have an even surface so I don't have any type of difference when I finished and bonded the restoration. We know also that electric hand pieces are very helpful as well for the fine tuning of these restorations. So we go for partial coverage restorations. You can see here the preparations for the veneers, and in the posterior teeth, we just recreate the occlusal space that we need at the new established vertical dimension. Okay, so we smooth out the occlusal surface. Okay, if it's not a very big smile and you're not going to be seeing the facial aspect of those molars, you can just maintain it as overlay in the occlusal surface. You see the bicuspids, they are von Leys, veneer and onlay. Not only veneer there because we want to get those bicuspids in function as well. The canines, 360-degree veneers because we are recreating that palatal surface that has been worn. And you can see the preparations of the anterior teeth. So we create a basic bisacryl shell, and with some bisacryl material, we go ahead and make the provisional. Something that I've learned is that it's important to work well on the cervical adaptation of your provisionals and your mock-ups. So when you scan them, you make a biocopy and it really transfers that information as you want, so you can avoid surprises later on when you're trying in and delivering the final restorations. You can see here the amount of tooth structures that we are recovering, okay? And this is the bisacral provisional. Always we make small modifications with Soflex discs, with thin burrs, and once the patient likes it, we go ahead and scan it because it's very valuable, the information that we can obtain with a good provisional once that it's been tested in the patient's mouth. Not all the time we can create a mock-up. Sometimes we need to first make reduction. So in the lower arch, I'm tired at this moment. We're not anesthetizing the patient in the lower in the mandible, so we just go ahead and place these bisacryl as a mock-up. But you can see now in the occlusal surfaces the differences of the shape, the height of those posterior teeth, and then the patient will start to test that new vertical dimension of occlusion. When the patient comes back for the third appointment, we will prep through the mock-up. That's the best guide in those areas, in the molars, okay? Prep through the mock-up there just to make sure that you have at least 1.0 millimeters. You can have 1.5 in your functional cusps, but make sure that is homogeneous, no spots less than 1. That's the key, okay? So that's exactly what we do on the third appointment. Lower preparations and of course the provisionals in centric relation. Here I will make sure that I got my buccal scan because I cannot get this in the second appointment because I haven't prepped the lowers yet. That's why I mentioned that splinting this provisional, the maxillary, for example, in this case, in 3 segments is very helpful to obtain that buccal scan. And then we would go for the fourth appointment where we want to create this trying and delivery. It's nice to see that this is additive dentistry, but we are being protective of the material in the future. It's going to be controlled that we have that same thickness in those second molars where there's more chances of fracture. So feldspathic porcelain is the most translucent material. They are polychromatic and can be adhesively bonded, and also they are monolithic, right? So we don't need to share the space. It's only one material, and that's something we really like to work with, monolithic restorations. As Jim said, now we have the VITA Trilux Forte in bleach shades 0M1 and 1M2 as well, which is something nice to be able to have a difference between the chroma on the cervical to the incisal. Okay, what do we like to use these ones for? Veneers, anterior crowns, and posterior crowns. Nowadays, with other stronger materials, you could say up to the second premolar, and this is being very conservative, very on the safe side. Okay, so you can see here the multichromatic block, how we like to tilt it so you don't get like a very clear difference between the thirds, and it's a nice natural diffumination. So enamel is the incisal third, has a low chroma and a high translucency. The body is the middle third and has an intermediate chroma, and that's what we need to use as a reference to select the block. And then the dentin has a high chroma in the cervical third. This is a screenshot of the Von Ley. This was described by Dr. McLaren. It's basically a combination of a veneer and onlay. When do we need this? In cases that we are reestablishing the vertical dimension, we want to enhance the buccal corridors, the aesthetic on those bicuspids, so we want to create veneers, but also that they are functioning in the occlusal aspect. But I don't need to break my contact point here. I don't need to prepare the palatal aspect of this type of restoration. So this is a slide I took from Dr. Blatz, my mentor, and here he explains very clearly the concept as well. If we have a defect below the equator of the tooth, then we create a butt joint. If we don't have any defect below the equator, we can just have a nice bevel and create more of an overlay. Okay, so considering the aesthetics, considering the function, we will come up with the final preparation design. Just to make sure here, as I was saying, one number, always 1.0 millimeter in the center fissure, and never hide the minimal thickness warning when you're designing on the CAD/CAM software, okay? Because we don't want to cheat on thickness of the restorations. Independently, if the material is pressed or it's milled, if it's homogeneous and the minimal thickness is maintained, we're going to have better success rates. This is another great work from group of Dr. Bailati, as well as Dr. Uspelzer, and we can make this type of partial coverage, as I said, pressed or milled as we do. And these are the supinity blocks for these overlays on the molars. For you using supinity or the ones that haven't used it yet, we have 2 levels of translucency, and that's something nice because we can have that freedom of selection. Usually I like to use not the high translucency, but the normal translucent on the supinity material. This is another study by Dr. Frankenberger from Germany, talking about the stability of endodontically treated teeth with differently invasive restorations, adhesive versus non-adhesive cusp stabilization. So what we want to have always is cuspal coverage. It's generally desirable for the restoration of endodontically treated teeth beyond a certain cavity extension. Typical case, patient with a class 2 or a fractured cusp and root canal, then we go with a full occlusal coverage restoration, but not necessarily a traditional crown. Okay, and this is another example from Dr. Blatz, how we want to have a putty matrix from the digital wax-up or the traditional wax-up to verify that we have the space. I like to prep over the mock-up, as I show you, prepping over the bisacryl, but also you can just cut this putty matrix so you can check tooth by tooth that you have sufficient reduction. And then we milled and stained and glazed. These are all monolithic. We're not adding ceramic. It's just stain and glaze. And we go for the 4th appointment, which is the trying and cementation. And immediately after cementing, we'll go ahead and create the night guard. So for VITA Suprinity, we need hydrofluoric acid etching for 20 seconds. This material has more crystalline phase, less glassy matrix, or so 20 seconds is the desired time for etching. And then it's a silica based ceramic, so we need to add a silane coupling agent for 60 seconds as well. You can use both 9% or 5% hydrofluoric acid, but maintaining those 20 seconds. And nowadays we use the mostly universal adhesives. It's basically a one-step self-etch adhesive that can be used with the previous acid etching. So we do always total etch when we are working on enamel. We have a mixed environment between enamel and dentin. We do selective etching, but these adhesives can also work without the need of phosphoric acid. So this is an example how nicely we place the phosphoric acid on that enamel rim, and then you can see the etch enamel surface. We go ahead and place the bonding agent to both the dentin and the etch enamel. We place the rubber dam modified in the facial aspect, and then we do the trying, and then we will go with the adhesive cementation. In the lowers, as I said before, what was the success of those feldspathic onlays we did more than 10 years ago? Material thickness, then we had a rubber dam isolation for a real adhesive cementation. So I don't see how we could bond these type of inlays and onlays on the lower molars without rubber dam, because it's very difficult, almost impossible to maintain control in that area. And then the cool thing about these protocols, right, is that we are taking the important concepts of prosthodontics, but making them in a less invasive approach. In this teeth, for example, we only add some direct composite, reshaping that incisal edge of the canine, but now we have the space to create a nice cuspid there that it won't be fracturing because there's a very few material, or there's no room for the material, which is the most common problem when clinicians want to go and treat the patients in MIP, where there's been already a loss of that vertical dimension of occlusion. It is a great quote by Dr. Pascal Magne. It shouldn't not be about aesthetics, but tooth conserving dentistry, right? So I think that's something we need to keep in mind as well, to try to make things look better, but at the less expense of mutilating the healthy tooth structure. So here we go and do the adhesive cementation protocol of the Suprinity onlays, and then we start removing the excess of cement. I really like to take these occlusal photos because I can magnify them in my computer or my camera and find excess of cement, and then I can start removing and polishing with the ultrafine burrs and the silicone burrs in low speed. I like to use the VITA Suprinity polishing kit. There's one for intraoral use, so it helps me smooth out the transition, the margin, and having a very nice aesthetic result as well. Okay, so these are those spathics in the anteriors and Suprinity in the posteriors in a full mouth rehabilitation case where we reestablish the vertical dimension of occlusion at a low cost of mutilating healthy tooth structure. Okay, so I'm gonna play this quick video here and we'll continue with the last case. Okay, so now very quickly, I would like to finish with the second case, and it's pretty much a very similar situation when we have some patients with older dentistry, some PFM restorations in single sites, for example, and we want to enhance the overall health and functional and aesthetic of these mouth, we can always work only in one arch to increase the vertical dimension, and then the opposite arch, we can just individually restore those teeth without needing to work on both the upper and lower arch. So this is the same. This is feldspathic ceramics in the anteriors, and these are suprinity restorations in the posterior teeth with the same approach. We want to create rehabilitation in centric relation with re-establishing the vertical dimension of occlusion at the lowest expense of healthy tooth structure. Okay, so I think this is something we can all do it clinically if we have this 4 appointment sequence. It's also doesn't make it that hard on us and on the patient working all day. So I would have half a day or 3 hours on these longer appointments, but you can have a clean sequence of what the step-by-step would be. So lower teeth, I didn't touch them. These are feldspathic ceramics on the posteriors. We work on the full upper arch, and we reestablish 2 or 3 millimeters exactly depending on what we need in the posterior to have a nice blending with the new incisal edge position and the curve of the smile. So Dr. Fradiani's book is a great support. Dr. Belzer papers with that table of the different steps of what we need to focus on, the planning, on the wax up. Those are important tools that can help us on a daily basis. Even though now all our wax ups are done in the computer and all of them are printed, these basic concepts will provide us the clinical success, whether it's feldspathic ceramics or a silica reinforced material. So it's exactly 1:03 for me. So I think we're on time. And if there's any questions, I'll be happy to answer the questions. So Jim, thanks again, and you can remove me from being the presenter. And if there's questions, I'll be happy to try to answer them.
Well, thank you, Dr. Conejo. Very interesting, a lot of good information, good workflow. You kind of methodically planned it out and communicated that. Loved all the studies that you had to back up what you were saying. So that's very nice to hear as well. I'm going to show my presentation, and then we will just go over a few last-minute items here. So everyone should see the PowerPoint that I have up. If you're looking for CE, you'll get a email from our marketing education departments that will ask you to fill out a form. We need to capture some of the information so we can create the letter or the MBC credits that you're looking for. It has been recorded, this webinar, like all of the past webinars with Dr. Conejo and others. It has been recorded, and then give us a couple days, but we will post it on our VITA North America YouTube channel, along with LinkedIn, Facebook links there as well. So we do have many recordings, as I mentioned, that are on the site. If you need to get a hold of us, you can always contact directly one of the reps that are local to you, and then they can help you out and get you in touch with anybody that you need to. You can also look at additional programs that will be coming up later this year. Dr. Conejo has another one on the 22nd of September. It'll be a different topic for that one. And then all the way through the rest of the year, we have these planned out for various topics and products and so forth. And most of them are not, we don't do a lot of commercial salesy stuff for these webinars. These are usually, like Dr. Conejo presented, a lot of scientific information, a lot of how to best practices, best methods, and so forth, just to help you and to educate you is our primary goal here. So please join us again. You can also contact us, the help desk here at VITA North America. There's the information. I will go back to it, but I'll bring that slide back up from Dr. Conejo. If you need to get in touch with Dr. Conejo, ask him questions, further up follow-up, and so forth, please do. He's been gracious enough to allow that, to field some of your questions. So, please talk to him, get a hold of him. I just wanted to mention Dr. Richard Truskowski from NYU says hi. He's someone we all know. Yeah. So the case with the application, did you do anything different than the previous one? Dr. Monnier suggests to use the IDS with the material like Kerr fourth generation bonding. What did you find? Anything different? What are you finding?
Yeah, so immediate dentin sealing has been documented for many years, and it's very helpful in many situations. What we see is that it's good to have the knowledge and the tools to understand that specific procedure, but I don't feel that it's necessary in every situation. Sometimes when we have these chronic diseases, right, that the patient has had this wear of these surfaces for many years, the response of that dentin is different when we have something, let's say, more acute, right? So we want to consider when to apply it, but it's totally valid and it's a very useful way to maintain a happy pulp, right? And that's part of what Dr. Frankenberger from Germany also mentioned, that these partial coverage restorations work much better over vital teeth than on devitalized teeth. So we want to work hard and try to keep those teeth as vital as possible. And also I've seen that after clinically 11 years of working with the chairside CAD/CAM dentistry, when we are able to deliver same-day restorations, that tooth basically doesn't suffer about provisional restorations, temperature changes during that typical, I don't know, 2 weeks between you send the case and receive the final restoration. So even just by applying chlorhexidine, cleaning well, and then do a good adhesive cementation, always trying to have a bonding agent on the tooth and being very meticulous on the curing steps, the rates of hypersensitivity really reduces a lot. So hypersensitivity is one of our main enemies as clinicians, and we need to try to tackle them in as much ways we can.
All right. Thank you. So another question, you had mentioned digital dentures earlier on. Someone had the question about, are you using canine guidance or group function? Is there anything different for digital dentures than there is traditional dentures?
So the question, Jim, of canines and group, is it for this fixed full mouth or for complete dentures?
Let's do both, just so we cover it. Okay. So make sure we answer it. So.
Okay. So in these cases, right, that we're working to supported restorations, full mouth rehabilitation, we want to make sure that we have strong centric contact points in the molars. I feel that sometimes we don't go to nature enough to really see what healthy people have, how many healthy contact points they have, and it's basically an average of 10 contact points per quadrant. So that's something that I always keep in mind when I'm designing. I want to make sure that between the two bicuspids and the two molars, I have 10 contact points. Those firm centric contact points will help me protect the anterior teeth. Of course, when we do the protrusive movements, I want to have these anterior guidance, as I said before, trying to have as many teeth as possible doing the this occlusion. And if I have normal canine teeth with a good bone, good long roots, those are used for having a canine guidance. If I have a group in one side with a bicuspid touching, it's totally fine. I just want to make sure that I don't have any interferences on the non-working side. That's what I always try to manage in fixed, okay? And if we go for dentures, complete dentures, we would like to have a flatter overall occlusal scheme, and we will have a different way of adapting this because this is not a fixed restoration. So I think we need to have a understanding of both different, let's say, worlds. And actually, the videos that I show, very nice how the protrusive movements were made. Those were from the VITA Physiodance campaign, maybe like 10 years ago from Dr. End. And I had the opportunity to be trained with him and learn a lot. And it's nice to see so many different philosophies. But what I go back always, we gotta make sure that this theory, this philosophy is something that we can all implement in the clinic. It's just very fancy theory, very difficult to achieve in the clinic. For me, it's nothing that I would like to start implementing, right?
Yeah, thank you for mentioning the video, because we did have several comments on asking what was the program that you showed that was a simulated video. So you captured some areas from Dr. N's video, very nice. So thank you. So another question, kind of a two-phase one, is when you're looking at shade and you're shifting the shade using a material, and I'll just throw out an example. If you have an A3 tooth, and you're going to go to A1 or you're going to go to bleach, at what point do you have to either use a material to mask out the underlying shade or mask out that prep before you proceed with the case? So they're asking kind of how far can you move a shade, shift a shade, by using the material by itself?
Yeah, that's a great question, right? Because that's a clinical challenge or difficulty that we all face. I think we need to understand that feldspathic ceramics is the most translucent material out there, but in a way, if we're starting with a very dark substrate and we want to go to something very light or very bright, we would need thickness. If I have 1 millimeter of material, then I would have the ability of, let's say, improving, I would say, 3 tones. But if I'm creating veneers that are 0.5, because I don't want to remove more enamel, but I don't want to have those teeth look more bulky or over contour, then I would need some help from a material that is slightly less translucent. And that's where I think, like, for example, the Suprinity translucent, not the highest translucent one, that translucent at a thinner diameter could be a good option for those situations. That's why we insist that we cannot just have one material, and it should be case by case. So other thing that I do to help out is the whitening before I start the therapy to try to enhance everything. And then we can maybe go with feldspathic materials, which is my favorite for the anterior region, but I need to understand that excessive translucency with a darker substrate could be negative if it's very thin, the restoration. The other part of the question, which is very interesting, was masking. If you go, there's another webinar we did, and I was showing the combination of having a very thin zirconia coping, conventional YZ zirconia coping, to mask endodontically treated teeth to be able to use then feldspathic ceramics on top. Personally, I don't like to use the opacers intraorally, those like flowable composites or direct composites that opaque that way. I like to use more indirect, because I can not only modify the color, but also I can recreate an anatomical coping that will match, let's say, the adjacent teeth where I have a veneer, because it's not only about the color, but also about the shape of the abutments when we're working with very thin feldspathic ceramics that need to be considered.
All right, thank you. Yeah, I think it was very important that you brought out that you let the patient, after bleach treatment, you let the patient sit for a week before you move forward, so that that bleaching treatment, it settles, which is very important, I think, before you start treatment planning shade, especially. So.
Exactly, and also you want to have that gap between a week or two to do your final adhesive cementation, so it's not affected as well. So for both better shade selection, as Jim is saying, and also to obtain the best bond strength when you cement them.
So another question, you had shown us some burrs that you use for clinical prepping. Do you have any specialized burrs that you use for finishing the restorative material? Do you have any specialized brands or burr sizes or shapes or anything?
Yeah, so the burr block that we designed was with Brasseler, and that's for prepping the teeth. But also in that kit, we have red line fine diamond burrs that with water work very well to adjust intraorally the occlusion, mostly with zirconia. Okay, with zirconia, you don't want to use a very aggressive diamond. So that football shape, red line with water, that's what we like to use to adjust any ceramic material and zirconia intraorally. And then extraorally, of course, we need to have multiple types of polishing systems. I like that VITA now is coming with a polishing system specific for the material, like the enamic polishing kit, both technical and clinical. Same for Suprinity. The one for Suprinity is the one that I use for ceramics, for feldspathic ceramics as well. And there are additional kits to polish zirconia, which are important to invest on them. Personally, I use the Brasseler one, and it works great. We know that zirconia is super biocompatible. I think we discussed this, Jim, in previous lectures, but that area of the zirconia restoration, that it's slightly subgingival in direct contact with the soft tissue, we want to avoid glaze all the way down to the margin there and just have that polished neck, I would say. So yes, we need to have multiple kits, and also this applies for the PMMAs. There are specific kits that are more trimmers instead of diamonds of low speed. The trimmers, that's what we need to use, and then the felt glots to get the best surface out of your milled PMMA provisionals.
All right, thanks. So another question was, what is your recommended technique for margin registration for patients that have lots of bleeding after the preparation? You have a technique to kind of isolate it, to restrict that blood flow so that you capture a good impression?
Yeah, I think the work there needs to be done previous to that moment. I like to prescribe chlorhexidine for 10 to 15 days before those appointments of making the preparations. So while the patient is using the chlorhexidine previously, we're going to have a direct effect that it will cause less bleeding. That's one thing that systemically would work very well. The other, of course, I like to use the 000 retraction cord impregnated in the hemostatic agent and have this very thin and rounded instrument to pack the cord, so I don't create any bleeding while packing the cord. And then I would say that trying to keep control of a small area at the time. With the intraoral scanner, I could, let's say, work on lower left, first and second molar, and get that scan and kind of get that area out of the way. And then I might need to work more on a second chord on the bicuspid and canine, and then I start moving forward, because sometimes it's really difficult clinically to create just perfect hemostasis in the 14 teeth and just go like boom, linear movement and scan everything. So sometimes we need to go like specific area at the time. But the prescription of the chlorhexidine mouthwash for at least a week before is something that really helps a lot. And of course, patients needs to go through a hygiene therapy and all that before we get into that aspect. There's also this instrument that I showed from Brasler that it's basically a shield to protect the soft tissue when I go around and I'm fine tuning the margin, because so many times I got frustrated because I wanted to be a little bit cleaner, go back again and smooth the margin, then boom, I touch it and then the blood came up. So it's important to get those specific instruments. They really help us and save a lot of time as well.
All right. So if you have additional questions, please get them in now. One other question, Dr. Conejo. This has to do with a patient diagnosed with that has bulimia, or maybe acid reflux. Do you have any experience on what the best material would be to use for that type of a situation?
Yeah, you can use a feldspathic ceramic or a silicate ceramic. We would like to kind of recreate that enamel that it's lost, right? So a stiff material like a ceramic in a way works well. So those are very common cases. You'll see it in the palatal surfaces of the maxillary anterior teeth and the occlusal surfaces of the posterior molars. So there, as I said, consider doing, let's say, full mouth rehabilitation approach, but being more conservative with this type of overlays on the posteriors and even these palatal veneers that we've done as well in this type of bulimic patients or patients with reflux.
All right. Well, thank you very much, Dr. Conejo, for your time and generosity to continue to educate people, dentists and laboratories. Everyone is on the webinar watching and listening. Any last words you want to hand out to the audience?
Yeah. No, thanks a lot for joining us today. And I think that nowadays is a great time to practice dentistry with all the tools and materials. But the basics are the basics. We got to make sure we take our time for treatment planning and to have a sequence, what I'm going to do in appointment 1, 2, 3, and 4. And that will make my everyday dentistry a little less stressful. And I think that's what we all want. And we will be having 2 more webinars with maybe some surprises. So stay tuned.
All right. Well, thank you again very much. Thank you, audience, all the participants. Appreciate you joining us today for another VITA Learning remote webinar. You'll get some information as far as CE down the road. Please join us again for an additional webinar with Dr. Conejo or others, or visit us on our VITA North America YouTube channel, or find the link through LinkedIn and so forth for recording of this video and others as well. Thank you again for joining, everyone. And this concludes another VITA Learning webinar. Thank you.